Hello, everyone. Thank you for joining us. I'm Kirsten Axelsen. I'm a visiting fellow with the American Enterprise Institute, and I'm delighted to be joined today by Amitabh Chandra, also with the American Enterprise Institute, and Craig Burton with the Association for Accessible Medicines and the Biosimilars Council. Today, we'll be discussing the Inflation Reduction Act and the implications for patient costs in the two areas that have the potential to most directly reduce patient costs, which are the availability of generics and biosimilars and the out-of-pocket costs that are charged through the benefit to patients. So I'm going to start off today by asking each of my panelists to introduce themselves and also describe their background and their relationship to the provisions in the Inflation Reduction Act. Before I do that, though, I do want to mention that I am, in addition to being a visiting scholar, I am also a consultant to biopharma companies and other life sciences companies. So maybe today I'll start off with Craig. If you give us a little background and your connection to this legislation and what will inform your position.
Thanks, Kirsten. So good to join you guys. Craig Burton. I'm the Executive Director of the Biosimilars Council, which is part of the Association for Accessible Medicines. I'm also the Senior Vice President for Policy and Strategic Alliances at the Association for Accessible Medicines. AAM and the Biosimilars Council represent manufacturers of generic drugs, as well as manufacturers and manufacturers who are working on developing biosimilars and who are trying to bring lower cost competition to the market. So beyond that, I've been in town for a few years in various roles in HHS, on the Hill, and so forth, but excited to join you guys.
Thank you. Amitabh?
Hi, everybody. I'm Amitabh Chandra. I'm an economist at Harvard University. I teach health policy at the Kennedy School of Government and investing in the life sciences at Harvard Business School. I serve on the Congressional Budget Office's panel of health advisors. And, relevant to today's conversation, my research over the past 2 decades focuses on 2 questions. One is, what are the links between pricing and innovation in the biopharma industry? And the second is, what are the effects of cost sharing or price transparency or any of these ideas that we are often exploring on patients' health?
Thank you so much. So before I turn to our panelists for questions, I'm going to go through just a few slides to orient all of us to what we're talking about today. Really beginning with what I'm going to be asking our panelists to consider is how the key provisions in the Inflation Reduction Act that affect medicines, which are price setting, price inflation penalties, out-of-pocket spending caps, and the redesign of the drug benefit, will affect patient costs and the market for generics and biosimilars. We'll also talk about how the law, while focused on Medicare, may affect access to and cost of medicines in marketplaces outside of Medicare, such as the commercially insured or people who don't have insurance who pay out of pocket. This type of a change in policy is really the biggest change to how drugs are paid for, really since Medicare Part D came into being in 2006. And really, it's the result of 2 forces, right? Like, as a result of the success of new medicines, we're living longer and better. And many of the new medicines that are available are very targeted to specialized conditions and have higher costs. Drug prices are a very popular bipartisan target to control. No one likes spending a lot out of pocket for medicines, and sadly, many people absolutely can't afford it, and that hinders their ability to live and to thrive as a result of medicine. So they're understandably a very significant target for cost savings for patients. Drug spending also is the easiest part of the health system to control, and is much more transparent than prices in, I would argue, almost any other sector. So just in a very brief overview, today in Medicare and in private insurance, net prices are largely negotiated between the manufacturer of a branded drug and the health insurer. And those negotiations result typically in a net discount, and that's how a drug gets placed on a lower formulary tier. Sometimes that occurs without a negotiation, or sometimes there's no negotiation and the drug is just placed on a lower formulary tier. generic and biosimilar competition enters in at the end of the patent life cycle, and typically prices go down when more competitors enter the market. The generics and biosimilars are the single largest contributor for cost savings in medicines, I would argue, to the entire healthcare system, other than perhaps good health. But we have not succeeded as a country in prevention or other large-scale initiatives that reduce the cost through better health. And so generics and biosimilars will continue to be one of the best ways that we can use our money most efficiently. And of course, because this law is focused on Medicare, the drugs and prices and access to both brands and biosimilars will be most affected in conditions that are most prevalent in the elderly, such as cancer, macular degeneration, autoimmune disease. I would say this law passing was not particularly a surprise to me. I think if we look back through history, just about every time there's a huge step forward in innovation and in when there's many new medicines launched that are transformational, such as what occurred through HIV or through the hepatitis C medicines, or even some of the cancer therapeutics, there is an immediate focus and backlash on drug prices. And so when we saw all the new therapeutics launched and vaccines launched for COVID-19, I think it was very consistent with the patterns of history that you would see legislation that would focus on ratcheting down price. So really what we're talking about is these two slices of the pie of total drug spending are that are in white are currently privately negotiated. That 28% that is the drug spending in Medicare as a proportion of all spending in the US will now have a portion of that spending with the price set by the federal government. There are 4 key provisions in the Inflation Reduction Act, and we'll be considering how all 4 of them affect patient out-of-pocket spending as well as access to biosimilars and generics today. It's the government ability to set price, it's the penalty on price increases, the limits on beneficiary out-of-pocket costs, and also the change in Medicare benefit design, where the federal government is taking on less of the responsibility for high-cost patients, and the health insurers and biopharma companies are taking on more of that responsibility, which of course some of that will be passed back on into the premiums that patients pay. The process will go as this in a very brief outline. CMS will choose from among the biggest drugs. They will consider these factors, may consider these factors. The biosimilar or the biopharma companies can offer data to support their consideration. CMS, the Office of the Federal Government that will be implementing this provision in the law, will then offer a price to the drug company. In reality, the drug company cannot really refuse this price offer without experiencing a large penalty. And then the maximum price will be published, and that will be the new price, which will be in place until the product has generic or biosimilar competition. The kind of price declines that we will be experiencing with these drugs, which are drugs who have been on the market for a relatively long time, 9 years for small molecules, which are pills that you would get at a pharmacy, and 13 years for large molecules, which are more complex, typically injected drugs. So for the drugs that are picked up at a pharmacy, the price declines will be 51 to 27% of the current list price. And for the drugs that are administered by a physician, the new prices as a result of this law will be 76 to 36% of the list price. That said, CMS is charged with bringing the price down as low as possible, so the prices could go below these benchmarks. Now, considering our discussion today, generics and biosimilars reduce spending for the federal government and for patients. $96 billion in cost savings in Medicare in 2019 due to generics. That is a significant portion of the total spending in Medicare, and I would say just about the only major contributor to cost savings in the Part D benefit alone. Of course, there's savings accrued outside of the benefit, such as reduced hospitalizations or productivity. 92% of all drug prescriptions in the US are generic. Generics reduced drug spending by 6% in 2015 to 2020, and we are expecting over $10 billion in savings from biologic loss of exclusivity in 2021. When you think about what that means for the patients is when they pick up a generic prescription in Medicare, the average cost is 58 cents per prescription. And then when we think about the dynamics of the generics and biosimilars business, Larger markets get more generic competitors. Larger markets experience a larger price decline, and larger markets see the prices decline more over time. By large market, I mean lots of prescriptions and big prices, big revenues. And so one of the things we'll be discussing today is when that price is pushed down at the end of the life cycle, what will that mean for the incentives for generics and biosimilars to enter the market? Drug companies will be imposed a penalty if they raise the price faster than inflation. Note, I think many times this is positioned as drug companies can no longer increase the price. That is not true. There'll be a penalty. It will be paid back to the Treasury. It's not paid back to the patient. However, this is expected to have an effect on the incentive to increase prices for drugs in the Medicare benefit. And this connects really directly to a lot of the work that Amitabh has done, and I hope will speak to us about. But a major difference for patients will be the out-of-pocket spending limits in Medicare, with a cap on total spending of $22,000, and certain drugs, including insulins and vaccines, will experience cost limits on those drugs individually. This will affect a relatively small number of beneficiaries. Roughly 4% pay more than $1,500 a year. However, those beneficiaries typically have a very high burden of number of prescriptions, and tend to take medicines that are for pretty serious illnesses. And to summarize some of the work that Amitabh has done in this area, when you increase out-of-pocket spending, it results in a significant and real decrease in the drugs that patients use. And contrary to what you sort of may hear in theoretics, it's not the drugs that are sort of the tertiary benefit drugs. It's often the drugs that are the life-saving medicines that are the ones that are left behind or reduced when the prices go up, when the out-of-pocket costs go up. So then finally, the other big provision in the law that will change is this increase in the decrease in the government's responsibility for these higher cost patients in the catastrophic spending zone. And we'll consider what that means both for government spending and for potential access restrictions for patients who are taking so many drugs that they end up with high costs. So just quick summary, some of the things that I think are some of the second order effects of the Inflation Reduction Act. Of course, some patients are going to see an immediate cost savings due to the out-of-pocket spending caps, and that is a significant and important benefit to their health. We can expect changes in demand for the drugs that have the prices set, and also potentially changes in demands for the drugs that don't have the prices set, that are now going to have a much lower cost competitor. But again, the cost differential between the brand and the generic is going to be reduced, which will have implications likely for entry and uptake of biosimilars and generics. So that's my setup. Now I'm going to turn to the interesting part, which is talking to the two of you. So I'm going to start with Amitabh. So considering the provisions in the Inflation Reduction Act that I just sort of quickly went through, how do you think the intent and the spirit of the law compares to what you think will actually happen in implementation?
I'm optimistic. I think the only part I disagree with is calling it the Inflation Reduction Act, right? Because that was just a political move. I think there was a bunch of good ideas that it has that we can talk about in the context of out-of-pocket spending by patients, and retiring the ability of manufacturers to kind of ending their ability to never sunset their drugs and things like that. But calling it the Inflation Reduction Act, I don't know why we did that. So I'll start with that. But in terms of the parts of the act that I'm most excited about, it's the big reduction in out-of-pocket in Medicare Part D. I hope that future incarnations of this act or other acts will think similarly about the incredibly high levels of coinsurance we have in Medicare Part B. Where, at least traditional Medicare, people face 20% coinsurance with no out-of-pocket max. And so that's certainly an opportunity where future incarnations of this law can use some of the good thinking we have in this version and apply it to that. I think the fact that we require or will negotiate drug prices after 9 years for small molecules, 13 years for large molecules. I know people are very upset about this, but at a high level, the intent of the law here is correct and pure. The monopoly power that we give manufacturers was never intended to be a permanent monopoly power. And so I think it is okay for government to say, we're going to sunset the monopoly power we're giving you. Now we can have a separate conversation, as we will, whether 9 and 13 and whether the distinction between small and large molecules makes sense. But I do think that that sunsetting of the monopoly power was good. The part that worries me, the part that I'm actually most concerned about, is the government's ability to negotiate drug prices. So the government's ability to negotiate drug prices will be much greater than the ability of private payers. And this will be viewed as a good thing, right? But it's not going to be a good thing if two things happen. One is the government just expands the list of the drugs it's going to negotiate over. So today it wants to negotiate the prices of 10 drugs or 20 drugs or 25 drugs. But tomorrow it says, let's just negotiate the price of 2,500 drugs. The US government's ability to do that negotiation is in many ways what I'm worried about. It's a much bigger government than any other European government, so it'll actually get much lower prices. And while people will say that's a good thing, it's not a good thing if that starts to slow innovation, right? And so when we're talking about 10 and 20 drugs, maybe you don't have large innovation effects. You talk about 2,500 drugs, you might start to have very large innovation effects. So that's something that I worry a lot about. The second is, right now, the IRA doesn't do anything about launch prices. It has as you noted, Kirsten, it sort of says you can't raise your prices faster than inflation, but it doesn't do anything to launch prices. We have known, and the public may not know this, but we've always known that it's the increase in launch prices that is the primary source of revenue growth for manufacturers. It's not these price increases that they take over time. I realize that is not what you read in the press, but that's just so at some point the government might want to take on launch prices. And I'm not sure a government really knows how to do that. Right? Government's ability to know what's on the minds of patients, doctors, society is probably a lot less than the ability of a private plan to do this. So if government is worried about launch prices, I wish it would think more about delegating that authority of negotiation to an entity like a PBM or a health plan, more than it doing it directly.
Thank you. So Craig, I'd like to ask you, how do generics affect out-of-pocket costs? We already talked a little bit about how out-of-pocket costs affect health. In which classes are generics most available, and what has that meant for patient costs?
Yeah, so thanks, Kirsten. It's interesting in recent years. One of the buzzwords in drug pricing policy has been discussion of value-based contracting. And I half tongue in cheek like to say that generics are the original value-based pricing when we're talking about drug pricing, because I mean that's what we see. Is you said today they're 92% of prescriptions, but only 18% of cost. So they are bringing a lot of value. I mean, what we see, and this is our data that we publish annually in the savings report. This is data that FDA has done, is that when a new generic comes on the market, the price drops rapidly. We're seeing price declines of anywhere from 40 to 90% off of that brand drug, and that is meaningful in terms of lower out of pocket for patients. It means patients. It's why patients are more likely to fill a generic prescription than they are a brand, is because the out of pocket cost is less. I mean, to give you a sense, I think that the average out of pocket for a generic is roughly $6, and the average out of pocket for a brand is in the $50. So patients fill them, they're more adherent. But I will say, one of the things we've seen in recent years is a trend towards patients nonetheless still paying too much for their generics. Their generics are being moved often, for instance, in Medicare, from tier 1 and 2 with a $0 or a $5 copay to tier 3 with a $20 or a $30 copay. Now, they may still be filling their prescription, but they're paying a heck of a lot more, and unnecessarily so. And when this happens, you have, what's really happening is a bunch of patients who are using generics are subsidizing healthcare spending for everyone else. So, this is a real problem. If we want patients to maximize the value, we want to encourage them to be taking generics. We need to make sure they're getting the value out of that.
Thank you. So Amitabh, you brought up, you'd rather, I will put words in your mouth, but the health plans negotiating price versus the government negotiating price. As we've seen in many classes, the health plans are negotiating prices that are 50%, 40% of the list price. What's the difference? Why wouldn't we just want the federal government to come in and get that same 50%?
I think it's because of the size of the federal government, nothing else. I mean, if you think about how many people the US federal government is purchasing health insurance for, the first order would be the sum of, folks in Medicare plus Medicaid. You'd get half the United States, right? So if the US federal government is a much larger country than Germany, than Canada. And so when the US federal government goes to a biopharma manufacturer, whoever that manufacturer is, and says, we want a price that is 60% lower than the price a commercial plan is getting. And if you don't give us that price, we're going to stick you with a 60 or 80% excise tax. It will get that really low price. It will. And I think folks will say, that's awesome. The problem with it being awesome is that now it's also discouraging, seriously discouraging, long-term incentives to bring drugs to market that benefit the kinds of people that the US government covers. And I don't want that. I don't want that uncertainty on firms. I do want drug prices to be negotiated, just to be very clear. So if we were a small country, this is not about, government being incompetent or something like that. If we were a small country, if the United States was the size of Rhode Island or Massachusetts, and we wanted to do our negotiation, it's fine, because there'd be some other big country kind of carrying the weight of the innovation. But if we're a very big country, we don't want our government then doing the negotiation. You want entities like private plans or PBMs or whoever, ACOs, or pick your favorite entity negotiating, because they're negotiating, but they don't have this ability to command the below normal price, which economists refer to as monopsony price, that the US government will be able to command. That's my worry. And just to be clear, I'm not saying as part of this argument that the private plans are doing it better than anyone else. I'm not saying that at all. I think that the private plans could do it a lot better than they are. They could be a lot more transparent than they're being right now. But I do like the fact that none of them are, even though they're huge, like Express Scripts probably manages more lives than Germany, than the entire population of Germany. So they're big in that sense, which I like, but they're not as big as the government.
So Craig, can I ask you, what are the dynamics of the generic market? How has it changed in recent years? And have we seen the sort of savings from small molecule generics exhausted? And why have we not seen the biosimilars market grow as fast as everyone said it would? It was supposed to save us, biosimilars. Yeah,
so a lot of good questions there. I'll unpack them, the kind of in reverse order. Biosimilars, why have we not seen the savings everyone wanted? Because we're all impatient. We want everything yesterday, to be frank. And I say that half jokingly, but look, I think we've seen the first biosimilar actually launched in 2015. Since that time, data we released earlier this year, since 2015, biosimilars have generated $13 billion in savings. Half of that came last year in 2021. So what that tells me is that biosimilars are starting to figure it out, right? And so what you're seeing with biosimilars is a natural learning curve where providers have to get comfortable with the products, patients have to get comfortable with products, and so I think you're starting to see that. Obviously, this next year is going to be a big test for that, as you have the Humira, the adalimumab biosimilars coming to market with with 7 or more biosimilars coming to market there. I think there are some challenges. There's still some challenges. You have to make sure that your reimbursement and coverage policies actually encourage use of the biosimilars. So if you want someone to use the lower cost product, you better make sure that your reimbursement and your coverage policies are designed to actually create that result. Unfortunately, that's not always the case. You know, we know there are instances where providers make money based on the cost of the drug. So if you want them to use the lower cost drug, you need to align your policies. Same thing with coverage. If you want plans to utilize and really drive biosimilar adoption, then you've got to think about the role of rebates and whether plans are inordinately incented to go with the high priced, high rebated drug. So that's kind of biosimilars, just a couple points on biosimilars. With generics, I would say, I mean, you know, provocative question, have we exhausted the savings? I don't think we have, but what I think you're seeing is a shift to the more complex specialty molecules. You know, those bring with them different competitive dynamics. We have seen, you know, you talked early on about the role of rebates in brand negotiation for formulary coverage. Well, historically, generics do not rebate. Generics compete based on list price competition. It's head-to-head where they're competing based on 2 factors, price and volume. But in the past 5 years or so, we've seen a trend of slower generic adoption. Not in all molecules, but in some generics. And one of the big drivers of that is slower formulary coverage of new generics. And I think that is a dynamic that you can trace back to the role of rebates. Does it, you know, it's not applicable in every market, but it's clearly applicable in some of the specialty markets like Advair, like Gleevec, to name 2. Where generics are now saving, but it's been a much slower adoption curve than you might have historically anticipated.
Thank you. And then a follow-on question to that, Amitabh, how do you think for the drugs where the prices are reduced through the maximum fair price, government price settings, how do you think that's going to affect the market for generic and biosimilar entry? And sort of what does that mean for long-term cost savings?
Yeah, Kirsten, I think that is a part of this law that we have really not explored as rigorously as I would have liked us to. So if I read the IRA and I go back to your opening comments, just to kind of level set for the audience, you know, I remember that, for example, what the law says is that, look, if the government is negotiating the price of a drug for a drug that was approved, say, you know, 16 years ago, then, you know, the maximum fair price should be no more than 40% of the current price. Right? That's kind of like the high level description. And if the drug was approved, say, 12 years ago, then it should be no more than 65% of the current price. Now think about what that's going to do. Why in that world do I need a generic? Why do I need a biosimilar? Because the government is able to get the branded price down to the point that it is maybe even better than the current biosimilar price, maybe even better than the generic price. So, you know, on the generic, one thing we know about generics is it's not just when, you know, the price doesn't just fall when the first generic enters. You really need a robust market of many generic entrants to lower the price. That's one reason that biosimilars have probably not saved as much money as we thought, because right now we're still in the early days of entry. It's only when it becomes a really big, thick market that the biosimilars will start to drive down the prices of drugs. But with the IRA, I am statutorily getting a price that is better than the generic price, that may be substantially better than the biosimilar price. So why would people need generics and biosimilars? Now, folks listening to me might say, well, yeah, maybe we don't. But that would be incorrect thinking, because nothing forces the manufacturer of a drug to keep making the drug 16 years after they launched the drug. So it could be the case that, you know, a manufacturer launches a drug. In year 12 or year 13, the government says, you know what, buddy, we want a 65% price discount. And the manufacturer says, yeah, I'm just going to stop making the drug. Not as a threat, but I'm just literally, I don't want to make this drug. And now we don't have the great generic manufacturers around the world and in the United States coming in, right? So the right way to have done this is for IRA to have said, you know, what we're going to do is not demand that low price, but actually we're going to force the entry of generics and biosimilars on a particular date, right? And let that market competition drive down the price. That would have been an alternative way to do it, and in my view, a much better way to do it. Because nothing requires a large manufacturer, an innovator manufacturer, to keep making old drugs. Society doesn't want them to make the old drugs either. They're not particularly good at it. Their capital is much better deployed doing R&D on new drugs than making the old drugs.
Do you want to add something to that point?
Well, look, I couldn't agree more with that. You know, a lot of when the Biosimilars Council expressed concern about this legislation, a lot of folks were legitimately surprised about that. And we try to be clear. Look, we're not arguing for higher prices, right? I mean, biosimilars, generics are all about bringing lower priced products to the market. And even biosimilars, and we're still, as Amitabh said, we're still in the early days. But even there, the average biosimilar price is half what the brand price was when the biosimilar first launched. So we're in the early days of a race to the bottom in biosimilar pricing. Even the issue is, you know, we think long term, biosimilars and generics are a better way to ensure savings. They're a better way to ensure consistent supply. And so what biosimilars and generics are going to need is predictability. And this legislation, as Amitabh said, it doesn't address the timing of when a generic or biosimilar can come to market. And frankly, you know, folks want to talk about what's held biosimilar savings back. Look, we've had 7 Humira biosimilars approved and waiting to launch, and held back by 140 plus patents. You know, so if you want savings, the pathway, the model for driving savings is really clear. It's to make sure that biosimilars and generics can come to market, and that your payment and coverage policies are aligned to actually encourage and support their use.
Right. And there's so again, I think this is exactly the kind of nuance that's missing in the public discourse. I think neither Craig nor I are actually saying that the core intention in the IRA to sunset the monopoly provisions are bad. We're actually saying that was good. We're saying that, but the manner in which the IRA does it was not, just put it bluntly, it was not very smart, because what we're doing is, we're not thinking about what it means to have a robust generic and biosimilar industry. We're assuming that innovator companies will continue to make these medicines for years and years and years. Why would they, right? Why would they? They're not trying to run a generic business or a biosimilar business. Their shareholders will say, hey, we invest in your stock because of the new products you bring to market. That's your expertise. Why are you investing in, why are you carrying all this legacy manufacturing to build a generic? So I think there was another way to do this. And I think what we could have done is either done something like, look, at the end of 13 years, everything sunsets, all the patents sunset, right? I don't know how the PTO feels about that. That's one way to do it. Or simply say, look, you can't infringe on another company's patents, but we will start to look at the end as on this particular date.
Yeah.
Amitabh, could you brought up a little bit the comparison of the timing for the small molecules versus the large. I think the average time on market without competition is about 12.5 years, right? That's been pretty constant.
Yeah.
So how do you think that dynamic is going to influence where companies put their investment and then, I guess, long-term cost to the federal government?
Yeah, I think that the honest answer is we don't exactly know all the details, but at a high level, here's how I am thinking about it when I'm teaching this, right, in my classes. So I'm a company and I'm deciding, I've got some money that I want to invest. And I'm thinking in my little NPV calculator, how much money can I make over a certain amount of time? With the IRA, I have 9 years since I launched the drug to make my money, and before I start to deal with the US government coming in and wanting to negotiate prices if I'm making a drug that a lot of Medicare, Medicaid beneficiaries use. With a large molecule biologic, I get 13 years. So holding everything else constant, I'm going to want to shift my current R&D towards the large molecule drugs just simply because I have 13 years to recoup monopoly profit instead of 9. That's a big deal for companies. Like we know that companies respond to 6 months of exclusivity. So if you give them 4 years, that's a ton of incentive. And that worries me. It worries me first because I don't think that society should be betting on a modality. I personally am indifferent over what improves my health. It could be a small molecule drug. It could be a biologic, or it could be no drug at all. It could be like drink a cup of coffee every day in the morning. I don't want to privilege a particular modality, and that's what we've done. The second reason I don't like privileging the large molecules is because that's where the biosimilar entry has been slow, right? So it might be early days, but it's still been slow, simply because there are much higher barriers to entry. The regulatory requirements of launching a biosimilar are much greater than the regulatory requirements to launch a generic. And so you don't get as much entry. And so if anything, I would have wanted to privilege the small molecule drugs, not the large molecule drugs. And third, and I'm the most uncertain about number 3, but I do think that small molecule drugs are likely to be the future for Alzheimer's, right? Because these are the drugs that are likely, they're going to be able to cross the blood-brain barrier easily. So for a bunch of different diseases, I would like to bet on small molecule innovation. And so then coming along and saying, but we give longer, exclusivity for larger molecules just seems kind of inconsistent with that. So those are at least 3 reasons why I worry about how capital might get allocated in ways that society didn't really want. Excellent.
This is my last formal question to the two of you. So my colleague at AEI, who's gotten questions from the audience, just so you're prepared for that. Maybe we'll start with Craig. What do you think the Inflation Reduction Act will mean for the federal government in terms of long-term cost savings? Is this really going to be a cost saver in the long term? Or do you think some of these puts and takes that we've discussed and the impact on the generic market may have an effect on what the anticipated cost savings are?
So really good question. Look, I kind of going back to what Amitabh said at the beginning of this, there's some really good stuff in this legislation. Mm-hmm. The redesign of the Medicare program is long overdue and is very good. Would I quibble with a few of the details? Yeah, but that is very positive. It will encourage plans to use lower cost generics and biosimilars. That said, it could do more, if they were to address some of the structural incentives in Medicare towards the use of rebates. So I think that's going to be positive. The $2,000 out-of-pocket cap is obviously positive. The additional add-on payment for providers to use biosimilars is a good first step. There's probably more that's necessary there, and that can generate additional savings through adoption of biosimilars. I think as we consider the cost implications of this bill, I think the real wild card comes back to these negotiation provisions. And that's on two levels. One, just did the CBO model get it right? And that's everyone's favorite parlor game, is to take issue with how CBO makes projections. But I think it's very possible that CBO is projecting savings on drugs that might not necessarily get negotiated. Because the legislation says they're not negotiated if a generic or biosimilar enters. And so we don't know how this is going to play out, but I would not assume that every drug CBO included in its model for savings is necessarily going to be negotiated. But secondly, I think it's going to come back to how CMS implements this, because while the legislation is notable in overall its very prescriptive approach, it's almost a paint by colors approach to legislating, where CMS is given very clear instructions of how to implement various provisions. There are nonetheless going to be issues that arise along the way as CMS implements this that will affect the long-term costs. And one of those that we've raised is, look, now that this is law, CMS, we know you still want generics and biosimilars to come to market, but for that to happen, our members, manufacturers of generics and biosimilars, need predictability. They need predictability about both what's going to be negotiated and how CMS is going to arrive at that price. Because biosimilar manufacturers are making the decision to invest anywhere from $100 to $300 million years before a drug is going to be negotiated. So to Amitabh's point about your NPV calculations, there's a big giant question mark in there. And one thing that all companies hate is uncertainty. So the more predictable, the more transparent CMS can be about how they're going to choose drugs, how they're going to price them, and how they're going to implement the 2-year delay for biosimilars, the better off, certainly, I think patients are going to be through generics and biosimilars.
Amitabh, other than what Craig already raised, do you think there's going to be, where do you think the cost savings are going to materialize, and where do you think we're going to be surprised where there's actually cost increases as a result of this law?
So, I mean, I think that there'll be a variety of cost savings. My guess is, I won't repeat what Craig said. My guess is we're probably more optimistic about the savings than we ought to have been. The worry that I have with this law is not only CMS's implementation, but let me bring up a particular part of it. CMS is trying, I think, right now to be very thoughtful about how to negotiate these prices. That's wonderful. I want a thoughtful government negotiating prices. But the government's going to very quickly figure out that it doesn't need to be thoughtful to obtain the lowest price. It should just use its full size as the US government to get the lowest possible price. So CMS can try to duplicate whatever ICER is doing, but it's going to quickly figure out it doesn't need to kind of do any of that math. It doesn't need to be thoughtful about how you create value and measure it. It can just say, I want a price that is 60% lower than the current price, and it would get that price even if it was the wrong price, right? What would prevent government from getting the lowest possible price? So that's my worry. I think coming back to CBO scoring, the CBO was tasked with an impossible task. CBO was asked to tell Congress, as a result of the IRA, how many fewer drugs will come to market. Who cares? It's not the number of drugs that matters at all. It's which drugs. And that's something that we don't actually know the answer to. We don't know which drugs will not come to market. And so the number 8 or 10 or whatever is irrelevant. That's kind of point one, right? The second point is that when CBO estimated the 8 or 10 number, it assumes that the IRA only affects R&D decisions made after phase one. In other words, it's assuming that venture capitalists don't care about future rewards, which is just not true, right? Like, even if the VCs don't stay with an investment for more than 10 years, their exit price depends on the price 20 years from now, right? So I thought that was a simplification that CBO made. I think they're clear about that in their scoring, but it's something that the press and Congress and, all the folks who kind of think about drug pricing it just got buried. And I think it's unfortunate. So that's a place where I certainly want to go back and think about that, because I don't think that savings are a sufficient statistic for social welfare. There could be drug savings, but in the long run, you could reduce innovation. You could do things like, really chill the biosimilars market or the generics market, all of which would be bad for patients.
Thank you. And my final question is going to be one from the audience, which is, I think, for Craig. Why would you ever have an instance where the patent term had expired, but you don't have a generic? Why does that ever happen?
Yeah, good question. So, a couple of possibilities. So first of all, when we're talking about, the key here for negotiation is not that the patent has expired, but no generics or no biosimilars are on the market. As Amitabh said, they just set a date. And frankly, that date does not line up with when biosimilars are likely to enter the market. They set a date, especially on the biologic side, where it is highly unlikely that biosimilars will be on the market at year 11 or year 12. Right? I think by law they can't be on the market before
right.
then. So,
it would be right, exactly. You would break the law.
And kind of a problem. There are certainly instances, we've seen this. There are some outlier products where that have no patent life, no exclusivity remaining, where there are no generics on those products. And the reason is going to vary based on the product. Sometimes often it's because it's a niche product, with a very, very small market, and there's just not enough of a market to encourage generic competition. It's possible that it's a particularly complex product, but I think that's pretty rare. So it's generally, look, a good example of this product was the product that Martin Shkreli took advantage of. It was a niche product. He saw the market opportunity. I think it was $7-8 million product before he bought it. There was no need for or reason or incentive for generic competition. What he did then was jack a price and make it attractive to generic competition. So I think those are rare. I think the key here is, as Amitabh mentioned, is making sure that generics and biosimilars can enter at the earliest possible stage, as they navigate, either the Hatch-Waxman or the patent dance requirements of the legislation.
Wonderful. Well, I'd like to thank you both for a good discussion. And as Amitabh said, we still have a lot to learn and a lot to see how this will all roll out. And certainly some good news for patients, but also some things that we will hope to see optimized in the actual implementation of this that will continue to support an industry that has improved and extended our lives and also brought down costs significantly. So thank you both. And thanks to all who joined.
Thank you.
Thank you.